Communication and interpersonal skills. Listening, listening and nonverbal communication. Listening is an active process that involves the reception and selection of auditory information, the generalization and interpretation of this information, and the reconstruction of what was heard. Listening is fundamental to quality clinician patient communication with the goal of engaging, facilitating, and encouraging the patient to speak openly and feel comfortable with the healthcare provider. Strong listening skills also contribute to accuracy in diagnosis, collaborative treatment planning, and patient satisfaction. There is five listening techniques. We're gonna see first the listening techniques. Preparation. Preparing to listen by setting aside appropriate time for discussion, free from distraction. This preparation serves to build rapport, increase one's ability to anticipate the patient's actions and responses accurately, and improve patient adherence and satisfaction. Paraphrasing is number two. Paraphrasing is repeating in one's words what someone has said. Paraphrasing serves to confirm one's understanding, validate a patient's feelings, convey interest in the patient's experience, which builds rapport, and highly important points. 3. Reflection. Hearing the patient's verbal message, interpreting the meaning of this communication, and conveying this interpreted meaning to the patient in an effort to ensure understanding. That is reflection. Hearing the patient's verbal message, interpreting the meaning of this communication, and conveying this interpreted meaning to the patient in an effort to ensure understanding. Next, acknowledging, continually conveying attentiveness and interest through verbal and nonverbal means, including leaning forward, maintaining good eye contact, facing the patient, asking questions, summarizing points and concerns, nodding, smiling, and maintaining close proximity. And the last one, interpretation, identifying the underlying reason for a communication. Interpretation serves to build rapport, increase patient trust, and comfort with disclosure, and raise issues for discussion that may be important but with which the patient may be uncomfortable in initiating dialogue. Next point is going to be in the nonverbal communication. This involves the expression or reception of meaning through nonverbal means. This is facial expressions, gesture, eye contact, interpersonal distance, dress, touch, vocal tone, rate, and rhythm of speech. Nonverbal communication may take the place of motiv- Nonverbal communication may take the place of, modify, or regulate the flow of a verbal message and express emotion and interest. Characteristics of nonverbal communication are going to be continuous, autonomic, and informative. Continuous. One can continually monitor a patient's nonverbal communication even when not engaged in verbal exchange. One also can convey empathy and other messages to patients through nonverbal means. Next, automatic. It often occurs on a semi-conscious or precognitive level, allowing for additional insight into patient's emotional experience. Attention to a patient's nonverbal communication is important to understanding their experience and identifying and addressing concerns and discomfort. And informative, the reception of nonverbal information can contribute to an understanding of patient's emotions when a patient lacks the awareness or the ability to describe them, adding to a rich, multidimensional perspective of a patient's experience. Rapport is the third point. The first one was listening, the second was nonverbal, the third was rapport. And it's a mutual sense of trust and openness between individuals that, if neglected, compromises communication. Rapport is reciprocal. Patients are more likely to respect a clinician's beliefs and opinions if the clinician is willing to listen to and respect theirs. Strategies for building rapport include greeting each patient by name, maintaining good eye contact, smiling, asking about patients' interests like work, school, family, and disclosing some personal information as appropriate. Next point, empathy. Empathy is the active interest in an effort, oh, is an active interest in and effort to understand others' perspective. The characteristics of empathy are understanding the patient's situation. For example, how would I feel if I were he? And two, reflecting that understanding back to the patient. For example, what can I say to him to let him know that I understand he must feel? Next, a clinician who effectively conveys empathy builds rapport and trust, elicits and addresses the patient's feelings that have the potential to interfere with treatment, assists the patient in assuming responsibility for his or her feelings, accepts the patient's feelings as real and important, and remains objective and non judgmental. Empathy is of the utmost importance because a patient who feels understood is most likely to disclose important information fully and accurately, feel confident in and adhere to the provider's treatment recommendations, and feel satisfied with the care provided. To facilitate good communication, care must be taken in verbal communication. Using the following techniques requires caution in carefully constructing the verbal message. Again, as, to facilitate good communication, care must be taken in verbal communication. Using the following techniques requires caution in carefully constructing the verbal message. 1. Presuming. Assuming a patient's thoughts or feelings may undermine rapport. Alternatively, alternatively, ask rather than presume. Next. Second, over assertive communication. Verbal communication often is driven by a strong emotion or the belief that one's perspective is the correct or only perspective. Alternatively, clearly explain your impressions and recommendations respecting any concerns or differing views a patient may have, and taking the time to evaluate and discuss different views of treatment options. 3. Reliance on technical jargon and abstract or vague communication. These may cause confusion and undermine rapport. Alternatively, be simple, specific, and direct. Next, giving advice. Giving advice can interfere with patient adherence and patient decision making responsibly. Alternatively, provide information and education to the patient so that he or she may take an informed decision. And last one, providing reassurance. Providing inappropriate reassurance, example, telling a patient everything will be fine, can backfire and result in compromised rapport and trust. Alternatively, provide accurate information, discuss any patient concerns or questions fully, and offer support. Next, professionalism. Professionalism is an essential component of the clinician patient relationship. Professionalism is characterized by confidence, care, warmth, and appropriate ethical professional behavior. Professionalism in communication may be conveyed in numerous ways, including leaning forward, maintaining eye contact, using facilitative nonverbal communication, e.g., smiling, nodding, maintaining a relaxed posture, exhibiting appropriate facial expressions conveying respect and interest, and practicing ethically. That was the first part of listening. That was in the communications and interpersonal skills. Now we're going to see clinical interviewing. Clinical interviewing is an art of communication that serves many functions. It allows the clinician to collect vital health history information. It serves to establish ground rules regarding communication, e.g., the level of formality or informality, how a patient may express emotion, how a clinician is likely to respond, and what is acceptable self disclosure and what is not. It provides insight into a patient's response style and attitudes regarding their understanding of dental health and hygiene and toward illness and other health problems. It assesses the patient's perceived needs, e.g., their presenting problem. It assesses it assesses the patient's values, what is important to the patient, bright smile, straight teeth, etc. Now, numerous interviewing techniques are useful in eliciting important health information and facilitating communication. Open-ended questions. Open-ended questions. The use of open-ended questions invites a patient to express what or she feels is important, strengthening rapport, etc. For example, what brings you in today? That's an open question. What brings you in today? Next, um, no, and same point is in general, it is preferable to begin an interview in an unstructured manner and progress to a more structured format. This approach provides patients with an opportunity to express what is important to them in seeking the clinician's services. Now, closed questions. Closed questions, direct questions that can be used to provide more guidance for response or to elicit specific information. For example, have you ever required premedication for a dental examination? Too many closed questions in sections can lead to patients' disengagement. Next, closed questions with options. Open questions that restrict potential answers by providing options, e.g., so, what are you hoping to accomplish? Reduce the need for future intervention or find a quick and inexpensive option? So, you're letting him decide between two options. A that is a closed question with options. Next, leading questions. Leading questions direct the patient to respond in a specific way. For example, that didn't hurt, did it? Leading questions are not recommended because they may easily undermine trust and rapport. Next, probing. Probing allows a clinician um, to gather information regarding a particular topic without leading the patient towards a particular response. E.g., tell me more about the discomfort you've been experiencing in your left lower teeth. Next, laundry list questions. These questions ask a patient to respond from a list of given choices. For example, is the pain sharp, dull, constant, or throbbing? Next, summarizing. Summarizing, chaining together a set of reflections. The clinician hears Clinician hears the patient's communication, interprets its meaning, and conveys a brief summary of one's understanding of what was said. Summarizing a patient's communication conveys understanding and concern in addition to encouraging further comment. E.g., I understand that your denture has been quite uncomfortable for you and that it feels as though it is irritating your upper gum. Next, transitioning. Transitioning. Acknowledging the importance of a patient's communication and shifting to a new topic of discussion. Next, silence. The use of silence, a silent pause in communication encourages the patient to speak. Next, verbal and not verbal facilitation. These facilitative gestures and brief comments convey interest and warmth in addition to encouraging further comment, e.g., head nodding or I see. Empathy. See earlier discussions on empathy, listening, and nonverbal communication. And next, observation. Commenting on a patient's behavior, especially that which is inconsistent with the patient's verbal communication, may encourage the patient to discuss a topic which he or she may be uncomfortable but that may be important to treatment. E.g., you seem uncomfortable when I mention the use of local anesthetic. Okay. So now when you do the treatment planning is the next. Remember that the first point was listening and nonverbal communication. The second one was um, clinical interviewing. Now the third one is treatment planning. Treatment planning is a joint agreement between the clinician and patient regarding shared decision making and collaboration. If a treatment plan is not acceptable to both the patient and clinician, it is likely to fail, even if the treatment selected is a treatment of choice for a particular presenting problem. Treatment plans involve many elements. Presentation of diagnosis. It is important to be clear, use language free of technical jargon, and use illustrative methods, radiographs, pictures, drawings, to ensure that the patient fully understands the nature and origins of the presenting problem. A clinician should be sensitive when relaying information that may be difficult to hear and with which people to cope and with which to cope, e.g., presenting indications of oral cancer. Next, proposal of treatment approach. The clinician presents treatment alternatives to the patient in descending order of desirability, e.g., treatment of choice, option 2, option 3, no treatment or referral. Be sure to present only options that are consistent with your standard of care and that would be acceptable to you. Next, presentation of potential treatment benefits, hazards, and patient responsibilities. Provide a comprehensive review of potential benefits and hazards and patient responsibilities in language that may be easily understood by the patient. Verify patient comprehension. To verify patient understanding, ask the patient what his or her understanding is of the treatment options. The clinician listens to the patient convey his or her understanding in his or her own words and corrects and clarifies any information as needed. Discussion. It is important to provide an opportunity for patients to ask questions about the treatment alternatives and to allow sufficient time for discussion. As comprehension and comfort increase, satisfaction and adherence increase as well. A treatment decision is the last one. Although a clinician may have a preferred treatment approach, the decision is ultimately the patient's. Use caution in giving advice. When a patient takes responsibility for choosing his or her treatment, adherence, follow-up care, and satisfactory satisfaction improve. Support the patient in his or her decision by providing encouragement. And last one, document. It is important to document the completion of each step of the treatment planning process. Patient education is an important component of treatment planning, as well as though throughout treatment. A patient who is well informed is more likely to adhere to treatment and follow up and report satisfaction with services.